So at the outset, I would like to thank Dr. Pooja and Dr. Rohan for inviting me to this excellent webinar. Well, Pooja, she asked me to cover up this topic about, usually I am used to showing the surgical videos, but here I'll be talking upon how to counsel a patient for glaucoma surgery and how to choose the type of the surgery and the ideal patient. So actually, this is a very tricky situation which a surgeon is usually faced during the course of clinical assessment of the patient. So whenever you have a glaucoma patient, you might be having a newly diagnosed patient, or you might be encountering an established case. So both these cases, they present their own challenges. If you have a newly diagnosed patient, you have your own challenge of making them understand the terminology of glaucoma. This in itself is a very big challenge, because when you tell them that probably they are suspects and you suspect them having glaucoma, they just look at you with blank face. So that is where the challenge actually begins. And then you provide them with all sorts of literature to study, to go through it, make them much more aware about what the disease is and how seriously should they be actually considering this disease. Secondly, you might have established cases. Established cases, they have their own challenges. You might be having a patient who is very well compliant, but then you might be even having non-compliant patients. They just do not tend to follow what you are being advising these cases. So anyway, whenever we have a newly diagnosed patient, you need to explain them the importance of their role in their own treatment. That's very important. You have to explain them how to put eye drops and the possible side effects, especially with the prostaglandins. You need to explain them the importance of the timing and how to put the drops, and explain them about all the side effects, which usually women, they are much more conscious about it. Secondly, we also need to explain them how the treatment is going to help them, what should they be expecting in near future, and how the things might progress, and what should they do if there is a drug allergy and if they forget to put eye drops. So these are some of the basic things, that these patients, they usually have all these queries, and we need to explain them. So this is in itself a very big challenge. Next, it is, why is it difficult to make the decision for surgery? Because there are many things in this glaucoma. It's totally a different, completely different clinical entity. We all know. The point with this is that patients do not see better, and they are often worse after the surgery. In case if the patient tends to develop some kind of complication which might occur in a case. So the benefit of what we actually happen to see in other surgeries, patient goes in for a cataract surgery, does under topical anesthesia, comes out, patient is happy patient. But that's not the case with glaucoma, because already everything is compromised in these eyes. So often patients, they even fail to understand that what actually you have done for them and how the things are going to progress in near future. Some patients, they also develop the transient loss of vision, which can happen after a filtering surgery. We all know there is a possibility of it happening, although it does not happen very often, but there's always a possibility, and we need to explain that to the patient quite well in advance. Some of the patients, they do not always see or understand the need for surgery given the slow asymptomatic loss of vision that's typical for glaucoma. So that is one of the things, many times patients, they wane off from the modality of treatment. You tell them to put the drops twice a day, thrice a day, they will be putting just once a day, something like that. So the compliance becomes a very important factor for this. Why is it difficult to make the decision? The next thing is that, there is a risk associated with the surgery. All the surgeries have their own risk and complications. I don't say that it's only for the glaucoma. Any surgery, you take a patient on OR, in your OR, there is always a risk of developing a complication. But these eyes are already compromised. So therefore, it's always challenging with these cases. The next challenge that a glaucoma surgeon faces is that, when would you advise a surgery? Now, this is again a tricky thing, because, then again comes in the surgeon's preference. Maybe I would prefer having a patient, if I put up a general term, maybe if the patient is on 2 drops or 3 drops, and if it is not controlled, the glaucoma is progressing, maybe we advise surgery for the patient. But that might not be the protocol with the second, with another surgeon or with the third surgeon. They have their own protocols set up of how they have been seeing the benefits in their patients. So they try to go around with what they feel is good for their patients. It also depends a lot on the clinical scenario. It's always a mix and match that goes on in a glaucoma patient, as Dr. Sood was saying. You look at the fields, you look this, you look at the intraocular pressure, you look at the history, you look at so many aspects coming up, you look at the nerve fiber layer, many things which come across, and that is when you start deciding. One of the other factors is also the patient's life expectancy, whether you have a young patient, a middle-aged patient, or a patient who is quite old enough. So then again, you have to weigh down the pros and cons of the surgery. How much is the intraocular pressure? What's the type of glaucoma? Because now these are the deciding factors in the glaucoma surgery. But it's a unilateral, bilateral. Even if you're seeing it unilateral, you always have to monitor the other eye also, if there's a family history. So these are some of the cases, some of the criteria, some of the aspects that you have to consider before you take up a patient and you decide that, okay, I'm going to do surgery for you. The next is when and whom to operate. Now, surgery is often the mainstay of treatment for certain types of glaucoma. They are usually the secondary glaucomas, the development glaucomas. So that is where the surgery, it often tends to come up in very early stages. But then there are cases with open angle glaucomas and all, which are well controlled with medications, where you try to postpone the surgery and you try to monitor the patient on the medical line of treatment. Surgery often is offered, coming up to our Indian scenario. We are a developing country. So in our country, many of the things, they tend to differ from the other world. That is, in a developing world, we have many limitations which are there in our setup. There's a lack of availability and the affordability of medications many times. So then you might opt in for surgical intervention in early. Suppose if the patient is not going to come back to you for a follow-up, or the patient is uneducated or something like that, maybe you might consider surgery even in early stages. There's a lack of regular long-term access to the medical care in remote communities. So these are the cases, where you might consider taking up these cases for surgery, because you know that the patient is not going to put drops or something like that. Surgery is often indicated in open angle glaucomas, especially in those with advanced stage of primary open angles at the time of presentation, and especially if the patient is younger. So these are some specific cases, where you would choose up these cases for surgery. But then again, I would like to say that this is, again, it depends on lots of permutations and combinations which are going on. The next thing that you have, which eye to operate first. Now, these were the questions that we were discussing previously in our discussion. So these are all the eye with a higher intraocular pressure and the faster progressing visual field. That is, these are some of the things which are commonly followed by, I think, many surgeons, by many glaucoma specialists across the globe. In advanced glaucoma, which eye would you operate first? So that is, often you need to take up cases where they have a better vision. The eyes with better vision are advised to take, especially when you have a one-eyed patient. That's again challenging because one eye is already lost in glaucoma, and then you have another eye of the patient. So now there will be a group of surgeons who will be considering that, no, it's a one-eyed patient, I don't want to touch this patient. I will try to manage this patient as much as possible on the medical line of treatment. And many of the surgeons, they are not ready to take the risk to operate this case. But there might be some group of surgeons who would be advocating that, yes, it's a one-eyed patient, we cannot take any chances with this eye. So I have seen many of the surgeons going in for surgery at early stages in these cases. But then again, I said before, it is always, surgery is something that it actually depends upon your results, your experiences, and varies from surgeon to surgeon. So this is another challenging thing. The most common surgeries that we come across in our scenario, in the Indian scenario, is the trabs and the tubes. These are the two most common things which are being performed in our country. Trabs, they are the favorite of everybody. It's the gold standard in glaucoma surgery. Usually surgeons, they do it with the antimetabolites. Mitomycin C is one of the most preferred drug as an antimetabolite. And it remains the most commonly performed glaucoma surgery with a very high success rate in most of the group and glaucoma diagnosis, especially in the hands of an experienced surgeon. So there is another group wherein trabs, they do not work. You have advanced glaucomas, refractory glaucomas coming up. So in those cases, tube shunts are advised. The most commonly used are, I've seen many people, even myself, using Amag walls and the Bearwell device. But there are various other tube shunts also which are available as of now. And many surgeons, they have a lot of experience putting up the tube shunts. The tube shunt surgery has also come up a long way Previously they used to use a graft for that, and these days the grafts are also not used. So these surgeries they are really helpful when you are dealing with the refractory glaucoma, such as you have a neovascular or a uveitic or an iridocorneal endothelial syndromes or fibrous ingrowths, or patients who have had a previous VR surgeries or PKs, but the success rate for trabeculectomy is very low. So that is where the role of tubes comes in. But with general ophthalmologists, trabeculectomy remains the gold standard as of now for the surgical line of management of these cases. A lot of surgeons had experience using the express glaucoma shunt. It is considered to be a modification of the trabeculectomy rather than a tube shunt procedure. And by placing this shunt, instead of removing the tube tissue, a more standardized flow of fluid is maintained outside the eye. So even for a shunt surgery, you have to choose which candidate would you be taking up and which candidate would be benefiting from a shunt surgery. So there's a group of candidates who would be responding to this in a better way. The good candidates that we call it is those cases who probably have a very good, a freely mobile virgin conjunctiva, which is healthy, thick, and is easily able to cover the tube to the limbus. And secondly, if you need to have a healthy sclera under which the tube can be successfully inserted. On the other side, the poor candidates would be the reverse. You have a prior conjunctival surgical manipulation, which has already been done. So these cases are not good candidates for the shunt surgeries. Anticipation of any future conjunctival surgery, if you need to do, you have an unhealthy thing. That's if the sclera is thin, you should not be considering doing a shunt surgery. So going on to these different kind of surgeries and different things, although recently we do have MIGs coming up and lots of experiences in the Western world with the MIGs, but I think in our country we still have a long way to go for MIGs. But I mean, it's very difficult to cover up the entire thing, but I just gave a brief overview of what it would actually be and how we need to go ahead and handle our cases and advise them and counsel them and how they could benefit from this. Thank you so much.
Thank you so much, ma'am. We in fact had a patient today. He had a 0.9 disc with pressures of around 42 weeks ago. His pressure on maximum therapy today was 24. He has a NS2 cataract and with a vision of finger counting. What would you do? Like, how would you proceed? And because we know that the visual prognosis is 100% going to be bad, and it's not like that his vision is going to improve so much. So, ma'am, what would you suggest for the patient?
See now, Pooja, now what case you have put forward to me is that what I understand is it's nuclear sclerosis grade 2 with medications. It is the intraocular pressure is around about 24.9 CD ratio is there, and the patient's vision is counting finger 1 meter or 2 meters, whatever. So with grade 2 kind of cataract, if the vision is counting finger 1 meter or 2 meters, then it is but obvious that there is a very significant amount of involvement of the optic disc behind. So we do have to operate this case. There's no way that we are not going to operate this case, but then it comes with a guided visual prognosis that we need to explain to the patient. You choose which eye to operate first. The first decision is that. The second decision is counseling the patient and explaining the patient that, look, what I would do, that's what I'm saying, that you have two diseases in your eye. One is the cataract and one is the glaucoma. Both of them are contributing towards the decrease of vision in your eye. Probably the amount of contribution coming up from glaucoma is much more as compared to cataract. And currently we are trying to do a surgery for both of them. The recovery would depend upon your optic nerve status. And that what we expect is definitely, it is not good. So, but anyway, we are trying to do the best for you, and this is the best that can be done. So probably I would take up this case for combined surgery.
Thank you. Thank you so much, ma'am. Dr. Mehta, any question about that talk? Your comments?
No comments. No. When you are such experts as speaking, I just would have wanted Dr. Sood to opine on the same subject.
Yeah, even I would like to hear what he would like to do.
Yes.
For whom? I mean, you want for that particular case that is described?
Yes, for that case.
So, Pooja, you talked about this patient with a pressure of 35, 40, and this thing. Does the patient have glaucoma?
Yes, sir. 0.9 cupping.
Okay. So remember, a high pressure and a 0.9 cupping does not mean glaucoma until you've done the gonioscopy also.
Yes, sir.
Okay. So now let's say that the angles are open or the angles are closed. So if the angles are closed, this patient is anyway at high risk for a malignant glaucoma. My first step in angle closure, irrespective of cataract, would be to do a PI for this patient. And okay, so this is one. Now the second question is this patient your neighbor, or is this patient coming from a far off area where he's not amenable to follow? You will have to look at other factors beyond what you have mentioned. So my primary instinct would be to do a two-step procedure for him, a glaucoma surgery followed by a cataract surgery, because I think this is the better thing in a long-term perspective for pressure and glaucoma control. But suppose this patient is not going to come back, depending on the kind of practice you have, the kind of patient he has, then perhaps you're forced to do both together, which I think is a little too risky because of the increasing upthrust. You could have iris which is prolapsing repeatedly and all those difficulties on the table. So as a cataract surgeon, yes, we are very good at all this, but it's always good to have your heart beating less when you're doing surgery. So a two-step perhaps would be a shade better, but there can be a difference of opinion. And one of the reasons could be because I don't do cataract surgery. So I'm more inclined to think from a glaucoma specialist point of view, a two-step would be better, but I would look at other factors in the decision-making process other than what you have mentioned.
Two-step, but the glaucoma first. Generally, a cataract surgeon would mention that a cataract first and 6 months later a glaucoma. But very interesting. We want your perspective.
There's a scientific reasoning, sir. Pressure is very high. The cataract surgery by itself in this patient is not going to be easy. Now, if you do a long-term perspective, a glaucoma surgery followed by a cataract surgery gives a better IOP control in the long run as compared to a combined procedure. So it's not just a decision at that point of time or for the next year or 2 years, but for the next 5 to 10 years time.
Yeah. Do you see valve surgery replacing trabeculectomy?
Sir, I think there's a conscious effort to replace a valve surgery replacing trabeculectomy. I think there's a conscious effort happening on that. And in a country like India, perhaps it's not very good because having a foreign body in your eye, a glaucoma surgery by itself requires adequate follow-up. When you put in a foreign body there, your follow-up becomes more stricter. Implants, and I'm talking as a generalization at this moment, implants anywhere in the body have not worked in a long-term perspective. They always have a life. And that life we are yet to see because we have started implants in a large numbers. It's going to rebound back. The eye of a child is constantly growing. So we need to be cautious in implanting implant in an eye because it's going to dislocate over a period of time. Adults, yes, but I feel there is a need for implants, but not perhaps as a primary procedure, but perhaps when a glaucoma surgery or trabeculectomy has failed, or maybe 2 trabeculectomies have failed, that you would actually look at this. But yes, materials and techniques have got easier. Implants are an easier surgery to do, a difficult surgery to manage post-operatively, both for the patient and the doctor.
So you still primarily would do a trabeculectomy. Your surgery of choice would be. That's what I wanted to hear.
Yes, sir. First choice.
Yes, an emphatic
trabeculectomy, mitomycin C with releasable suture as a first choice.
And you also said repeat, if at all. If that gets blocked, you re-explore the same, you make a second one.
So, sir, it depends on who's done the trabeculectomy. Usually, if I have done it, I'm very confident that my costume will be patent. So if I have to think and the manipulations are not working, then I'll actually go ahead with a second surgery or a tube that I would individualize, depending on the indication.
That's what I want.
Himanshu, I want to know what you would do.
No, I'm not a valve guy primarily. Valve would be reserved for bad rubiotic glaucomas and all at this point in time. I'm not a primary glaucoma person that I would be.
No, I am asking you to the question which Pooja had put forward for that case. So you have a 0.9 CD, you have this. So what do you?
I'm a cataract guy. I would remove the cataract first.
Okay.
Yes, that's why I wanted a glaucoma opinion. And I respect that. That's what I wanted to hear, a clear-cut answer. Because to me, a lot of pressures go down with glaucomas, with cataract surgery itself. And as Harshul said earlier on, I can always go ahead and do a glaucoma later. But I wanted to respect the other person's point of view. That why his logic is very important.
Absolutely.
Thank you, sir.